The first panel that we've got, healthcare providers, as I mentioned earlier, is going to be moderated by Kathy Crompton. Kathy's the Director of Strategic Initiatives for the Stratford County Community Action Program in Dover. She's been a healthcare advocate and worked in several community-based organizations for over 30 years. So without further ado, Kathy, I'll let you introduce the panel and enjoy.
Good morning, everybody. You can hear me. I just want to thank the Department of Insurance for giving me this opportunity this morning, and I really hope that there's some really interesting discussion that can come out of this. This is really a passion of mine, is what happens to the consumer in the healthcare system. So I think that we're really hoping that the discussion and the questions are also related to what is happening to the consumer. Also, if you want to write to the Department of Insurance and tell a longer comment or have a comment that may be not germane to what we're talking about but is important, please remember that you can do that as well. So what I would like to do is just tell you who's on the panel, and then I'm going to ask them to briefly give a little introduction to who they are and why they're here today. So I'm going to start with Tom Sherman. Tom is a New Hampshire representative and a gastroenterologist in the Seacoast area. Tom, you want to add any?
Can you hear me? In the rock and roll world, we're told to eat the mic, but I won't do that. I wear three hats, really, that relate to the healthcare profession in some way. One is I'm a gastroenterologist with Exeter Health Resources, or core physicians in Exeter. And I'm a state rep from District 24, which is Rye and Newcastle, and I'm in my second term. And then my third one is I'm chairman of the board of a international foundation called Next Generation Choices. We have a campaign called Less Cancer, and we are fighting the forces of big money in trying to help people understand prevention and healthy lifestyles. And I'm happy to be here. Thank you.
Thank you. Next we have Gareth Dickens, and Gareth is the co-CEO of ConvienentMD.
Thank you. Yeah, so I'm the co-founder and co-CEO of ConvienentMD Urgent Care. We started ConvienentMD in 2012, and we currently operate 6 full-service, physician-staffed, walk-in urgent care centers throughout the state. We're growing rapidly. We have 3 centers opening in the next few months, and our goal is to provide the most urgent care services throughout New England. Our main philosophy, we sort of, our mission and vision circles around 3 core goals. First of all, we focus on the highest quality of urgent care possible. We are physician staffed. Most of our physicians are board certified in emergency room medicine with decades of experience. All of our team members are highly qualified and capable. So high quality is a big focus of ours. Secondly, we focus on an incredible consumer experience, because as we're talking about today, consumers are beginning to make the decision themselves rather than being referred by others, and providing an experience that is second to none is very important for us. And then thirdly is to provide the lowest priced healthcare services in our markets. So that's kind of our core value proposition, and grateful to be here to answer questions.
Thank you, Gareth. Next we have someone who addresses not only are we a body, but we're also a mind, and that is Abby Shockley, and Abby is the Executive Director of the New Hampshire Alcohol and Drug Service Providers Association.
Hi, Thank you for having me here. So I am the executive director of the short name is New Hampshire Providers Association, and we represent the prevention, treatment, and recovery service providers here in New Hampshire. I'm sure that you are all aware that we are experiencing quite a crisis with substance use disorders here in the state. And during that crisis, we are also experiencing a shift in how services are delivered. All of our treatment and recovery service providers are just starting to accept insurance and work with carriers, and therefore their consumers are very new to this field. And so we've been very informed over the past several months of the challenges that consumers are facing, the challenges that carriers are facing with providers and vice versa. And so I'm really happy to be here to be able to shed some light on some potential solutions, as well as to comment on what is working for this population and what might need to be some innovative practice that New Hampshire can take on.
Thank you. And last, we have Henry Lipman. Henry is the Senior Vice President, Financial Strategy and External Relations for the Lakes Region Hospital. Welcome.
Thank you. I actually represent LRGHealthCare, which operates both Lakes Region General Hospital, which is a PPS hospital, one of the larger hospitals, and a critical access hospital, Franklin Regional Hospital in Franklin. Immediate past chair of the Hospital Association. Also participate with Granite Health, which is introducing a Tufts Health Freedom Plan this coming year. And also on the sort of the purchaser side, city councilor, chair of the finance committee in the city of Laconia, which is a tax cap community, and health insurance and managing that cost is one of the biggest challenges we have municipally.
Thank you very much. The way that we would like to have the panel work this morning is that I will ask each of the panelists an individual question, then the other panelists are welcome to join in. And if we can hold the questions from the audience until the end of the panel discussion, I think that would work well. And if you have some burning question you just have to ask, you can just really wave your hand really fast. So I'm going to start off the question for Tom. And Tom, this question, again, is from the consumer perspective, and it's about the cost sharing that we're working with today. Do you feel insurance companies have an obligation to protect their members from the cost of care, or is that a role, or is their role rather, just to sell products to people who want to buy them?
Thank you for the question. That's kind of a difficult one. It's asking me to dive into the brain of the CEOs of the insurance companies, and I'm not very good at that. But I think realistically, insurers are selling a product, and they probably look at it that way. Hopefully they do have a mission to provide the best product, and that they also understand that this is not just a commodity, that these are patients and this is healthcare. And I think most of the CEOs of the insurance companies I've met do feel that way. But they are selling a product, and what consumers are looking for is the best product with the lowest out-of-pocket cost. And as we move into more cost sharing, if you have a product that supports smart shopping and can, for example, the product that will allow them to have a colonoscopy at a much reduced price if they go to the recommended site, that out-of-pocket cost is going to be less, and I think that'll make it a more attractive total package. So as premiums stay stable but cost sharing goes up, the more that the insurers can assist consumers with keeping that cost sharing, the actual out-of-pocket down, that makes it a more attractive product. So in a way, it's kind of a win-win. But again, the whole issue of cost sharing becomes a disincentive to actually seek health care or seek the assistance that you might need, or at least delay it. So I think that it's a double-edged sword. You have them trying to help find the best product at the best price, keep the cost sharing down by assisting with the smart shopping, but on the other hand, you still have increased cost sharing, and that's a disincentive to actually get help when you need it.
Thank you.
Yeah, I agree, Tom, and I think it sometimes feels unfair for patients given the lack of information that they have. So in our case, in urgent care, a patient will check in, and we do our best to try to figure out that patient's insurance obligation and what they may be responsible for. But ultimately, even at the end of a visit, we don't know, because the chart's not complete by the provider, to even know what their bill will be when they leave the center. So it's kind of like going to a make-believe grocery store where you walk around with your cart and you're there to pick up the things that you know you need for your family's health and wellness, but there are clerks in the grocery store that throw in extra things into your cart because they believe that those are also important to your wellness. But then when you get to the checkout grocery line, the clerk at the cashier can't tell you how much you owe because every customer in the grocery store pays a different price. And for that person to be able to add up all of the grocery items with all the different prices and tell you what you owe is a very difficult thing to do, even though they'd love to do it. It's very difficult to do. So they say, pay $50 now and, we'll let you know what the bill is later, right? So you leave the grocery store and you go home, and a week later you've eaten all the food, right? You can't take it back. And the grocery store calls you up and says, the $50 was fine for all of the departments except for the daily department. And it turns out the daily department costs $3,000. So if you could please just send us a check for $3,000 for your daily purchases. And, you can't return those goods because you've used them. You can't argue with the bill because that's the price that's been negotiated. And if you don't want to pay it, you're for sure going to have a collections agency coming after you, and your credit's going to be at risk. So it seems like a very kind of it's an unfair. It's difficult for consumers of healthcare, but at the same time, cost sharing is really important to help patients make the right financial decisions on behalf of underwriters and employers. It's important for them to be able to make decisions that are going to be in the collective interest of Medicaid, Medicare, commercial insurance. The trouble is they don't know what they're spending. They don't understand their deductibles. They understand 3 tiers of copays for the most part, and that's really it. So I think there's not only to the underwriters, I think we all as providers and consumers of healthcare and underwriters, we all have an obligation to protect ourselves. And more information and clearer, simpler information is certainly a way to help that.
Unless you would like to go first?
Oh, no, I mean, you
Okay.
said it. No, I mean, I think it's not only insurance companies that have an obligation. I think at the end of the day, we're all human beings and we're all part of communities, and the cost savings associated with kind of empowered consumers and providers that are familiar with the plans that they accept and carriers that have good relationships with the folks that they work with. I mean, that saves money in the end, and that trickles down to our economy and our communities. And I think, the human aspect of that obligation is also important to highlight.
Thank you. First of all, appreciate the insurance department putting together this information. I think it's helpful. I think where we're at in terms of the question, we're at the intersection of healthcare financing and organization changing to deal with two fundamentally diametrically opposed types of issues. One is unbundling of healthcare services makes sense, and integration of healthcare services makes sense. And it depends on the population that you're dealing with. For the well population, the unbundling is helpful in terms of insurers caring about the cost and providers caring about the cost. That's why you see new innovations occurring in the market. With respect to the integration of care, those who are the sickest, the 5% that account for 40% of the cost, the unbundling typically doesn't work well for them. So how we work together, both insurer, provider, and consumer, to navigate that to make sure, particularly right now, I think the way the system is evolving is that the access issue and those that are the sickest are the most vulnerable in how the market is working. So I think from a public policy standpoint and insurer standpoint, we got to work together to make sure that those who need the integration aren't left out in the cold and paying a lot more. Shifting the burden to the sickest people isn't necessarily the best social outcome. It's the best market outcome, but it isn't the best social outcome.
Thank you. And Gareth, I'll ask you this question. Why do you feel there's a strong demand for the ConvienentMD services, and how much does high-cost sharing contribute to that demand?
There's a high demand for our services because, and we spent 2.5 years researching the New Hampshire market before we started the company in 2012, and the high-level response to that question is that the emergency room is being overutilized for non-emergent issues. And what we found with both secondary and primary research is that there aren't enough primary care physicians in the state to handle all non-emergent episodic issues. So people ended up running to the emergency room for care and racking up bills that the underwriters have to pay for, and Medicaid and Medicare that are multiples more than what they should cost if treated in the appropriate format. So so it's really it's a lack of primary care, and it's what we found is patients either aren't attached to primary care physicians, and we actually help attach patients to primary care if they need them, or they are part of a panel, but they can't get in soon enough, and they end up going to the emergency room. And so when we started in 2012, there were 2 or 3 centers in the state run by hospitals, and those charging more like emergency room rates for their services. So we realized that there was a real need for urgent care services, because what we saw was that between 60 and 80% of volume, this is a nationwide statistic, 60 to 80% of volume in emergency rooms was non-emergent, and so you could actually take care of all of those patients in a full-service, well-staffed, physician-staffed urgent care clinic for a tenth of the price, and that was the real value proposition that we saw, and the need for the service was kind of instantly validated when we opened our first clinic. I mean, we've been busting at the seams in terms of volume. So.
Would you like anybody want to respond to that as well? Tom?
I would just add that we see in the traditional office setting, we are generally, especially with, as Gareth said, the inadequacy of primary care capacity. It's very hard to expand so that you can have immediate access. And so having that walk-in capacity is hard for traditional healthcare facilities or traditional offices to provide. So I think, but that's also what, if you look at the lifestyle of especially maybe the Gen X group, or and less so, I think my generation, which is unfortunately getting older, but the alternative is not good. So I'd rather we got older. We're used to the traditional make an appointment and show up, but that immediacy is not what the younger generations, my kids and the generation just a little bit older than them, are demanding. And they're demanding, I need help now, and it's convenient right at this moment, and you don't have an appointment, I need a place to go. And I think that's also what's driving this, is the consumer need for immediate access.
So I think what's just been illustrated is a good example of the unbundling, which, for those that don't need the emergency room setting, that's a good solution for them, and obviously having success with it. But, when you look at it from a financing the premium standpoint and what consumers have to pay, that infrastructure to support, the availability for emergency use, you've now carved out, if you will, the more profitable niche that might support that. Now, not saying that what's happening in terms of the unbundling is the wrong thing, but just in terms of how, from a public policy standpoint, a provider standpoint, we finance the necessary infrastructure, particularly when you get to the smaller communities in the area where that may be what's making that available or not. So I think as we go forward in terms of looking at this issue, that's an important dimension to be measuring and to get ahead of, because once it's undermined, it's hard to get it back. And I do think that the segmenting of patients into well category and sick category, there are, as you talk about, the younger generation does want the immediacy, but just for example, at our Hospital Association annual meeting, we had a presenter who was a young person, double lung transplant individual, and she was doing a presentation for us about what the patient experience was. That type of person needs a little different level of infrastructure, and for them to have a quality of life and for the insurer to be able to finance the component of it, that also has to be considered.
Thank you.
Go ahead.
So I'll just kind of comment on the immediacy piece, not necessarily from the generational perspective, but with specialty populations like those with substance use disorders, that's the piece that seems to be missing, and that's really necessary, because when somebody is ready for help, it's a 5-minute window, and they need to be able to walk in somewhere and get that care. Again, I can't comment on how kind of ConvienentMD structures interventions that way, but I think that's the really key thing to consider, is that from a consumer perspective, this population isn't going to be able to call somebody and make an appointment and be able to last another week until that appointment is met.
So just to respond to that, so so we have the kits on site to take care of overdoses and things
great.
like that, and we make appointments for patients for follow-on care in those instances.
Excellent.
And then just in terms of the unbundling of services, I think what I was always surprised by looking at New Hampshire, just per capita cost of care, is some of the highest in the nation, which is really surprising. And I think what you'll find is as we develop these low-cost alternatives and unbundle, I think what you find, just like in other parts of the country, is consolidation, elimination of overhead, and centers of excellence. So where hospitals get really good at a certain function and become excellent at certain things. And that's certainly how things have evolved in other parts of the country.
Thank you.
Can I just add one thing there?
Very quickly.
New Hampshire is an older state, and also you have to look at, when you're looking at insurance rates, you also have to look at the Medicare, Medicaid rates, and without making a long dissertation here, our Medicaid rates are among the lowest in the country, and our Medicare rates compared to our neighbors are much lower. So in terms of trying to make that balance work, it's reflected in the commercial premiums more than anybody would like.
Thank you. Abby, I'm going to address this question to you. Do you believe patients are more likely to skip substance abuse services more than other health care due to the cost share?
So I don't necessarily think that cost sharing is the first thing that people look at when they're trying to determine whether or not they're going to get help for substance use services. I think we see that more becoming the barrier once they've said, I'm ready, let's go. And then the provider says, all right, well, we need $1,000 up front, and then it's going to be a $7,000 bill because you need to meet your deductible. And then that's when the walls go up. And the other piece, too, around kind of accessing care is that I think the most important thing that keeps people from moving forward with treatment or asking for help is the shame and stigma associated with the disease. And so it's that piece about being able to kind of meet people where they are and get them into care kind of right away is the piece that I think is missing, because the cost sharing automatically kind of creates that burden. And the other thing too, just around the cost sharing piece with this population, is that most people who are trying to access substance use disorder services are people who have just experienced a crisis. They have just been in the emergency room, they've just overdosed, or they've kind of hit their rock bottom and they're ready for care. And so because this is a disease that people kind of delay treatment for more often than some others, that's going to mean that they're going to require a higher level of care, and that's going to be more costly because of how long they've waited to progress into the disease. And so incentives to kind of earlier interventions and earlier participation in treatment that might not be as high level as an inpatient facility are what I think is a really good solution for this population when it comes to kind of carrier plan design.
I'll pass.
Tom?
Yeah, I think cost sharing is clearly, as it increases, it's clearly a barrier. We have fairly expensive, as you saw on the slides, a colonoscopy is around $2,600 and maybe higher if you have multiple biopsies. And over the last 2 or 3 years, I've seen more and more patients saying, wait, I don't think I'll have that ultrasound. I don't think I'll have that CAT scan. I still haven't met my deductible. I still have a $3,000 cost sharing. And there's a couple of factors that I think are, as physicians and providers become more employees of corporations, is that it is harder for us to, even if we know that down the road is a lower cost option, to say, well, why don't you go down to Stratum and have your colonoscopy done by our competition, because it's going to cost you $91 as opposed to $839 out of pocket. That kind of one, loss of control, because it's hard to trust somebody else's colonoscopy. It's not like an X-ray, but also I don't feel any real corporate pressure to steer people to stay within my system, but it's much easier. They stay within my electronic medical record, they do. And so as we look at cost, and as patients become more consumer knowledgeable and understand cost, I think we're going to see a much harder issue from the electronic medical record standpoint, being able to track what the results of the tests that you've ordered are going to be, being able to trust the results. And so what I would like to see is both a seamless EMR and a better statewide system of electronic records so that we can access what's happening at other facilities with our patients. And the other is that we use quality benchmarks, especially in the lower cost alternatives. But it needs to be across the board. Just because somebody's board certified and or not board certified doesn't make them a good provider. And I think being able to come up with quality benchmarks and a quality profile, we used to call it a physician profile or provider profile, that is not driven by WebMD or somebody like that, but is actually driven with nationally accepted benchmarks and published, is probably a way to make sure that, yes, the cost is lower, but the quality is similar. And in my field, we do have nationally accepted benchmarks, and that would be the other component to cost that I think would be helpful in patients making a decision on how to spend their cost sharing.
Yeah. Go ahead.
I think on the cost sharing side too, like take the colonoscopy example, a difficulty for consumers is what ends up being preventative, okay, versus diagnostic, and what the cost sharing's going to end up being, and sometimes what's planned to be a diagnostic screening ends up being a diagnostic, and that changes the cost sharing. The other thing that's a limitation out there that I point out is that, some of the price comparison information, for example, at our facility, that, as we saw with the Gorman report, the cost sharing is becoming to such a level that people need financial assistance even if they have insurance. And sometimes when people are receiving price quotes, they're not able to take into account because the price quoting entity doesn't have the full information of what might be available, and that continuity of care gets disrupted based on a false set of assumptions. So I think that's one of the challenges out there in terms of transparency. Is transparency to a certain level. I think it's indicative, but it isn't necessarily determinative, because I think hospitals are, in particular, and other providers are having to develop new strategies to make the higher cost sharing components out there work, and that often involves providing either discounts for prompt payment or even charitable assistance.
Actually, Henry, if I could interrupt you, your question, that follows very well into your question, actually.
Thank you.
So your question is a little bit longer. Hold on there. According to Families USA, among adults with deductibles of $1,500 or more, 29.8% went without needed medical care because they could not afford it. For adults with deductibles under $1,500 per person, 19.6% went without needed medical care. So other than preparing patients to take responsibility for their financial liability, how does your organization attempt to manage these populations so they receive the appropriate care at the appropriate level?
So there's really several components here. There's the price component, there's the quality component, and the utilization component, which is, again, tying back to the Gorman analysis. On the pricing end, we have someone's total role now is providing price quotes for patients. And oftentimes, and I think you were, in your example of what happens even in your facility, you're not able to tell the patient what their cost's going to be. We work with the patient to help them ask the right question for what they're going to be occurring, because you can say, I'm getting this type of procedure, but if you don't know some of the coding, you're not necessarily going to get the right pricing back. So we have a person that will interact with their physician's office who can understand the medical terminology and the like, to try to help guide them. We can help them determine whether they would qualify for financial assistance. We can help them maybe discern whether this is going to be screening or diagnostic, those types of things. So that's on the price side of it. On the quality and utilization side of it, we've added embedded nurse coordinators to work with patients in navigating what's going on and to help them make decisions, because it's much less costly if you don't need to use the procedure than getting a good price on something you didn't really end up having to have. We've also, on another price angle, restructured pricing to, for example, in lab work, we've understand that, particularly with the integration of medical records, how important it is to have the lab work continuity. So we made a strategic decision to reprice our lab work to make it so that people wouldn't necessarily have to go away to get a good price on that. I think that the whole idea of trying to develop different strategies around the healthy and the people that have high illness burden and is really one of the things that we're trying to do, because the reality is there is going to be a certain amount of unbundling that occurs, and it's how to make that work constructively with the need for integration.
I have a follow-up question actually for all of you. My experience has been that I have spent a considerable part of my life trying to explain to people who were either uninsured, underinsured, or just not familiar with the medical system, how to use that medical system effectively, and what an insurance product actually means, and what is a co-insurance, and what is a copay. And that becomes, I think, a burden for now the private offices and the hospitals and counselors as well. Who should be paying for that, and where should that advice be available to consumers in a very easy format that's easy to understand and easy for them to turn to for help when they want it.
If I could, as a continuation there, I think you have to meet people where they are. And some people can use the internet and may be highly educated and sophisticated in how they can consume things. Other people need their hand held all the way through. And particularly people in the substance use disorder situation, they may have no capacity to navigate, and they need to be really handheld all the way through. So, that's part of also some of the infrastructure that we've had to add into, particularly to help people qualify for the New Hampshire Health Protection Plan, the exchange, and the like. And there needs to be multiple sources because you got to meet people where they are.
So you asked who should pay for it. So I always think about, I don't think about who should pay for it, but who should make the investment so that their organization can receive a benefit from it. So I think an investment by a hospital system like you guys are doing with trying to give price quotes could potentially create a visit, right? Create somebody using the hospital. I think insurance companies who are selling products to large employers, to create an app that can tell the patient where to go and how much it's going to cost on average, I think that is a compelling sales tool when they're going to larger employers with their product. So I think those two groups. I mean, for us, the cost of our services are low. So I think even in a higher deductible world, people are still utilizing our service because even if it was 100% of their deductible, it's still not very much money. But in the hospital environment where it can be, and for insurers who are trying to sell their plans to employers, having that capability, I think employers would love that. Employers want to keep their costs down, and they want their employees to know where they can go that's going to be cost effective. So
I would kind of like to jump into a slightly legislative perspective on this. We have the third largest popularly elected legislative body in the world in the House of Representatives with 400 of us, and so you can imagine what a patchwork quilt of opinions that is. Some informed and some not so informed, and especially on healthcare. But a lot of what happens in Concord is driven, unfortunately, by ideology. And the way people get to Concord is by voters voting them in. And I know that sounds obvious, but after an election, if it doesn't go your way, the answer is that's what the voters decided that. And the voters are the general public. And I think what we're seeing is that the general public is not very aware of these issues. The general public is electing officials who really don't necessarily understand all of the complexities, which is hard to do, of the healthcare environment. And what we end up with is people driving healthcare policy based on ideology rather than what's actually happening either in your clinic, or in the hospitals. And an example of that is what's been happening with Medicaid expansion and others. Most of us who are either practicing medicine or running hospitals understand the critical value of the New Hampshire Health Protection Plan, both in substance use disorders as well as behavioral health. That does not translate to the legislature, who has the trigger on, since they like Second Amendment issues, the trigger on their finger on the trigger. And so in the end of 2016, we may see that completely go away because the voters elected a certain legislature. And the impact of that is a loss of $200 to $300 million of federal funding, which would completely change the discussion here today. Completely. So the point there is that when we talk about cost sharing or we talk about the drivers of healthcare, from a legislative standpoint, it is critical that the legislature and the general public is educated on these issues, not only when it comes to their own personal shopping for healthcare, which is complex, but also when it comes to their how they vote and how they vote once they're in Concord, and the impact it's going to have on all of these programs and on the insurance department and on the Department of Health and Human Services. So when we talk about policy and we talk about what's actually happening on the ground in healthcare, it is there is an amazingly powerful, potentially powerful influence of what the legislature decides to do on these issues. And they are driven by the voters. And I think that's a real important point to make when you look at cost sharing, you look at how these plans are structured and the future in New Hampshire, because that policy can really drive what we talk about here in these panels.
Just 2 comments. Thank you for bringing that up, because I think it's really critical that folks understand that. I wouldn't be here without the health protection plan giving me a reason to talk about insurance coverage for these folks. Just to comment on your question originally, is that that the burden of educating the consumer is really starting to fall on our providers, and really even holding their hands through appeals processes and understanding what happens when they get they get a denial letter for medical necessity and things like that. And then the burden for educating the providers is really kind of falling on our association, because again, these are really young providers that have never been in the insurance world before, and they're just as in need of education around deductibles and when to collect copays and things like that. And again, I just have to echo, Henry's comment. I mean, when I was going, I just had a baby a year ago, and when I was getting prenatal care, I'm relatively educated around these things because I was able to call and ask why a certain CPT code was billed, and I knew how to go through that process, and I knew who I needed to talk to. But this population is really vulnerable, and they're not capable of standing on the phone on hold for an hour, transferring, to 3 different departments and knowing what a CPT code is. And so I think it's really, we're starting to see a shift, particularly in the behavioral health world, with providers needing to embed that consumer education into their services too. And because there is no really way to pay for that, that's just become a cost of doing business.
Thank you. I'm going to start back again with Tom and another question, if that's okay? Sure. And this actually, I'm going to skip this one because it was, does your office explain to people what the differences are between? So we've talked about that. So what about health insurance cost sharing serves as the greatest impediment to the efficient use of healthcare services provided by the patient? Is it affordability? Is it lack of information? Or is it that understanding of what the different terms in the insurance world mean?
I think in some ways I have to agree with everybody. I think we've touched on this. It's all 3. We have patients who have a stable, fully treatable disease who can't afford their cost sharing. Some of the medications that we use, hepatitis C, Harvoni, some of the medications that we use for inflammatory bowel disease, Remicade, Humira, these are multiple thousands. And in the case of Harvoni, a 12-week course is $90,000. That's 90 pills for $90,000. That's not affordable. And at least a significant portion of that is going to be coming out of their cost sharing. Lack of knowledge about cost and quality. It's very difficult even for providers to find out the answers on that. Because I've spent so much of the last 3 years working on transparency, I think about it as I recommend a procedure. I have no clue what that procedure is going to cost, and as we've talked about, none of us do. We don't know until it's done and maybe a couple of weeks later. And I have been steering patients to the New Hampshire insurance department website to get some idea of cost and cost comparison. And I think Mark's group is becoming another option. So I think there are more options, but that's clearly an area of great need. And then understanding deductibles, co-insurance, and co-pays. Patients are becoming smarter because the cost out of pocket is getting higher, but there is a certain population where they are not going to understand this, and they really need help, if not having somebody paired with them to walk them through the process, like a navigator or, and you know, it's interesting, there's data on people who have coexisting psychiatric illnesses like depression, and it costs on average $1,000 more a year to just bottom line cost if one of their comorbidities is depression. And I suspect that part of that is has to do with executive functioning, access to services, being able to cope with having to look through all three of these issues. So it's incredibly complex, but I think all three make cost sharing difficult for us and expensive for us to be sure that they are accessing the care they need.
And just to add to that, and it was Jen, it's Jen, right? Yeah, who just described the benefit buy-down effect that's going on, and I guess that would tie into affordability, but I think that's a massive impediment, and it's not, it's just to price the premiums. You know, you make a decision just to price the premiums appropriately so that your company can afford it. It's not about sophisticated plan design. It's just, wow, costs have gone up. Here you go, 20% increase. That's what I just got from my company. So I'm going to be an example of benefit buy down in 2015. So we're moving to a $2,000 more deductible just to make it affordable for the company and the employees. So I guess that ties into affordability, but that's a significant problem, and it's hard to understand why it's happening.
So I think this is a good example of where integration makes sense with when you have behavioral and substance use disorder problems. Those people, I'm sure the insurance companies have their database and are the most expensive patients, and where it makes sense for all of us to work together to make the investment to get them on a better path, because it's going to lower costs for everyone. And that's one of the things that, you know, again, the balance of how the market's shaping and shaking out, how we need to, from a public policy, you know, corporate responsibility standpoint and the public sector work together to make this work better. And, you know, getting the benefit under the New Hampshire Health Protection Plan and traditional Medicaid is, you know, a step in the right direction. But even with the benefit, people need a lot of help getting there, and I think that's important work that you're doing, Abby.
I would just, if I could just add one thing to that, and we're really today, and we're in the trenches. We're talking about what's happening on the ground and with patients and individuals. The cost to society of illness is massive. Smoking alone costs the state in decreased productivity, just smoking, over $1 billion a year. So when you start looking at what is delayed care from insurance companies cost sharing, you know, somebody has a high cost sharing, they don't go in, they don't access because they can't afford it. What is the cost? Well, the cost on that individual is X, but you multiply that by all the individuals who are delaying their care, and it's very hard to find what that number is, but there is documentation that what illness costs, both on a moral level in terms of increased mortality and morbidity, but also the actual dollars. When I was talking about Medicaid expansion, when we were looking at passage, I said, well, if you can't do the compassion component, look at the financial component and the fiscal component on the state, and don't look at how much it's going to cost the general fund. Look at how much the illness is currently costing us in our insurance policies and in our lost productivity. This is the big picture goal, and I think that's lost on a lot of us when we're down in the trenches trying to figure out how to get a patient through the system. the cost benefit of getting somebody successfully through the system, getting them well and getting them back to work is massive for the state. And I think we have to keep that in mind as we work on these trench level issues.
I think I'm going to ask a final question and then open it up if people have their own questions. But in preparing for this panel today, I was looking at how other countries are dealing with, in a private insurance market, co-pays and co-insurance and deductibles and supplemental insurance products for high deductible plans. And what they do consider are things like a person's income, a person's medical condition, the numbers of people in the family, what are the complicating factors that exist? And we don't seem to have that today. And so I'm wondering, would that make a complicated system so much more complicated we shouldn't even go there? Or is that some kind of way that we can begin to look in a rational way at how can we continue this reform to make it more affordable and more equitable for more people?
That's all you got.
What you described is,
You have to answer it or I will.
Take that.
what you described is actually happening in an unplanned way. It's happening in the worst possible way, where people are worried about losing their homes, they're worried about, not being able to put food on the table. I mean, eventually it becomes such a crisis that it gets either forced on the system to deal with. So a more proactive approach. And I think, again, I talked about this unbundling and integrated. I think if you can get the cost sharing right for the right services, I think it would work better. Because if for example, if you've got an illness that's going to keep you from working, your ability to do cost sharing is much less than if you're the working well who have, for example, an illness that would be in one of Garth's facilities, that your ability to, because you're working and still, your ability to cost share is in a different place. So I think, looking at that in a more constructive way, when we talk about what could insurers and providers do differently, I think working together on that problem, I think would be good.
I'll just
Yeah.
comment again just on Henry's, I don't know if I have a solution to your question, but on Henry's comment about integrated care, I mean, that is where we really see the most bang for our buck when it comes to behavioral health services, because somebody with an emerging substance use disorder kind of earlier in the disease might still go to their primary care physician. And that person, if equipped with the resources and tools to do so, might be able to have that conversation with somebody and get them into care earlier, which is going to save both the consumer and the carrier money. And then I think, I don't necessarily know if, I think, I understand the need for cost sharing from a business perspective. And I think, what we might want to start looking at for behavioral health is just redesigning how benefits look and how people, as Tom said, you do the calculation on the immense savings that you have when you treat somebody well and you treat the whole person, from not just treatment perspective, but also covering recovery supports and helping them to sustain their recovery so they're not ending up back in the emergency room following a relapse. And also looking at how network adequacy is met to make sure that access, again, at that point in time when it's being asked for, is available. And so I think, from the behavioral health perspective, I think there's some really innovative things going on, and there's some really nice pilots going on in other states with carriers to see how smaller investments can make a big change in how they're kind of they're saving money both on the carrier side but also for the consumers.
Gareth, anything?
I think we do have, for the least affluent members of our society, we have the concept of Medicaid, right? Mm-hmm. But that doesn't have any cost-sharing implications to it. So, and I don't know if utilization of Medicaid services is higher than other groups. and maybe that could benefit from some minor cost-sharing tweaks. But yeah, to echo what Abby just said, I think even with the system that we have, more sophisticated cost-sharing is as long as patients understand what they're spending and what they're responsible for, they should make better decisions. It's just very complicated.
Tom?
There is some cost sharing in Medicaid, and it will likely go up in the reauthorization, but it's not anywhere near the size that we've been talking about in the commercial insurers. I think there is a benefit to cost sharing. I think without cost sharing, we would not have as much transparency as we have at this point, because it's being driven by consumers saying, I want to know what it's going to cost because it's now coming out of my pocket. And I think that's been one of the benefits of it. But there's a balance. And when cost sharing starts being a deterrent to getting the care you need, that's a problem. The crux is if you're an insurer or a legislator or a provider is trying to figure out what is the system that will allow that incentive of cost sharing, the cost savings of cost sharing, but will be tailored to meet the needs, the medical and the health needs of the consumer. And I think that's where integrated care really comes in, and incentives by the insurers towards integrated care, providing sort of on the medical home model. Dartmouth has had a lot of success with this in some of their clinics, and I think that's where we'll see some real benefits, and being able to adjust and advise and optimally utilize the cost-sharing component. The downside of cost-sharing is a friend of mine has a medium-sized business, and his answer to cost-sharing is that he can't afford to have people miss work because they're delaying care, which they were doing until he covered their cost sharing with another set of insurance. That to me is like the Department of Redundancy department. I mean, it's just not a good solution. It's a terrible long-term solution, and it's going to drive up cost.
I think one of the things that as a state we're proud of is our status and transparency, and I think you're trying to build upon that, which is tied to what we're just talking about, is adding the quality dimension and the utilization dimension. In the Gorman study, again, utilization is an important factor. Getting the utilization right and will help with the cost-sharing component of this and managing that. And so I know that's probably as farther out than anybody's at in the marketplace in terms of transparency, but I think the importance of utilization that we see in the insurance department report here suggests we need to work on that piece as well in the future here.
Good, thank you very much. Do people have questions? Tyler?
For Henry, I heard your responses to how your system is responding to cost sharing in terms of better information for patients. But the question I guess I ask is your system in terms of how it delivers care evolving at all? I mean, we've got this cost sharing, we've got the ignorance that goes with it. Are there opportunities that you're taking advantage of because now the patient is making decisions for themselves and what have you?
In the ER is a good example where I think generally it's perceived that ER utilization sometimes is not the best place. So we've used a number of different strategies. At the beginning of the implementation of the health protection plan and exchange, we had a provider in triage, and we would do an EMTALA level screening, and if they could have seen in a primary care setting or an urgent care setting, we'd make that referral and make that connection. And so we've done that for a bit, and then we changed our strategy on the back end, working with embedded care nurses in the emergency department who are looking for patterns of high utilizers. For example, someone who used the ER 30 times in a month, well, it turns out they have a substance use disorder or a psychiatric problem that needs to get plugged in. So we're doing that in the emergency room. And then out in the practices, we've embedded nurse coordinators to help patients navigate. And we're also in the Granite Health realm we're looking at larger data sets to figure out where we have gaps in care and what we can do proactively to reduce variation in care and get the proper utilization down. I don't know if that's gets to what you're trying to get at. And also, I think, service-wise, we're trying to create, the typical structure of primary care office that Tom talked about earlier. We've started Saturday hours. We have pediatrics 7 days a week, trying to do things to keep people from using the wrong location or the more expensive location.
That's great. That's great.
Anybody else? Alex?
Again, maybe starting with Henry, you talked about the contrast between integrated care and unbundled care. And we saw in the presentation from Gorman that we have these two trends. One very strong trend towards increased cost sharing, and another one that shows that this model of point of service, giving consumers choice at the point of service is pretty highly utilized by the carriers. Do you think that this movement towards what we might call consumer-driven care is at odds with an effort to have integrated care, or to have care coordination, or to have accountable care organizations? Is there a tension between those things?
Absolutely, the tension. And I think the thing that really we all need to work on figuring out is, when you're well and you just have a time limit, you got a splinter you can't take out yourself, you got an earache you can't cure yourself, the types of things that are appropriate, for example, in urgent care, it's very, or a lab test that's routine, it's very easy to unbundle those things and create a setting. When people move from sort of the well category to the ill category, you need a different type of strategy. And right now, I think we're working on, if 5% of the people are driving a lot of the costs, and we have this issue of substance use disorder and mental health as being a driver of cost, I don't think we're putting enough attention on that part of the equation yet, and we're not necessarily making the right investments yet in that. I think we're working in that direction, but I think sorting that out is something that we all have to work on. I hope some of your data might, in the future with this report, help point us in some directions where there might be opportunities.
And could I add to that?
Sure.
So, it's a bit, we're describing this as sort of polar opposites, unbundling and bundling, and I don't necessarily think about them that way. I mean, I think even your non-hospital-based outpatient services can still operate as part of the concept of bundling. So, and the more information we have about quality specialist providers, panel availability, same-day appointments, we as non-hospital-based providers can make sure that if patients require follow-on care, that they go to the most appropriate places. So hospital systems can provide that to us, insurance companies can provide that to us, and we have the systems we have in place, and we're just one example. It's very easy for us to know if a Harvard Pilgrim patient walks in the door, and if Harvard has informed us of the highest quality, lowest cost follow-on providers, we can make sure that if there's any follow-on care needed, we can make sure that patient gets an appointment. We make the appointment for them. So there is still the ability to bundle, even if it's outside of the hospital setting.
I would agree with that, but I do think it gets, when patients are in a different place, for example, how things are priced. The colonoscopy example, someone who is morbidly obese, heart condition, the way that things are reimbursed, the person who is a train wreck waiting to happen, the reimbursement behind that patient is the same as someone who is a fit, 30-year-old, may have a family history of it, but no problem. And so I think, again, how we design the system and structure things can be reformed. And I do agree with you that we can work together, and it's to our interest to work together
Yeah.
to overcome that for people who need the integration.
Yes.
Following up on Tyler and
I'm
Alex.
sorry, can I just interrupt? Martha has asked me that I repeat the questions, but your questions were so complicated, I couldn't say the words. So I apologize if people haven't heard, and I will try to repeat them as I can.
Following up on Tyler and Alex's questions, how much do you think that the market can respond to these issues about the tension between bundling and unbundling, and who needs what kind of care when, and how much is there a need for legislation? What are the barriers to having that actually happen?
Well, I think we need a balance, because particularly when we're dealing with the geographic coverage in our state of the large tract of land where the population's less dense, the vulnerability of that infrastructure is great, and the needs of that population tend to be greater. So I do think we need a mix of both. You know, it's not a perfect market. It needs, just like we don't have banking be completely unregulated, you need rules of the road to make sure that people get served, don't get redlined. We don't want people in the state healthcare who are sick to be redlined from having access. And I think that's one of the key functions that the insurance department can help, along with the Department of Health and Human Services and the legislature.
And just from a legislative, the balance, it's all in the balance, and the balance is providing guidance if needed, but not getting in the way of innovation and moving forward. A lot of this is being done without legislation, which is certainly, that would be my biggest hope, is that this would be done by the people who are the stakeholders, including patient advocates, moving forward to make sure the system is as smoothly integrated as possible. But certainly if there are identified areas where legislative framework is needed, there's a lot of willingness to work with the hospitals, with the insurers, to move forward with that supportive legislation. I don't think there's any one area right now. It's such a quickly moving target that the biggest worry I would have about legislation is that it would get in the way. And we've had requests for legislation on other issues where we've sat down with the stakeholders and said, you guys work this out and let us know if you need something. And it almost always ends up better. And I think we looked at transparency issues for 3 years, and what we ended up with was a commission to track it and to make sure that it stays on track. But we kind of wanted to be out of the way and then be available if something were needed. And I think that's in New Hampshire, where the legislature really likes to let systems and businesses figure things out, and we're small enough where you can include all the stakeholders. I think that's always been, or almost always had, the best outcome.
So from the kind of the business perspective, outside of legislation, I mean, if you just think about the big stakeholders, so for us as an example, a group that could be very instrumental in making sure that we provide the right follow-on care, the appropriate follow-on care, would be an insurance company. The insurers have contracts with us, and they could embed that requirement into their contracts. For us, hospital systems are also incredibly strong in their markets, and they usually own their physician practices. And so for us, and I'm not sure about the ambulatory surgery centers, but for us, we want to make sure that primary care patients who can't get in to see their primary care doctor after hours on the weekend aren't going to the emergency room. So we want to work with the hospital system to make sure that after hours they call us instead of go to the emergency room, right? And the trade in that is the hospital system making sure that appropriate follow-on care happens. And there's contracting around that too. So I think those are the two big groups that can really drive change outside of legislation.
I'm sorry, I think I'm getting the hook. So if you have individual questions for any of the panelists, you're welcome to approach them afterwards. And I thank all of you, and I thank all of the panelists.
Thank you.